Welcome to the Deep Dive. Today we are focusing all our attention on a condition that impacts nearly 500 million people globally, diabetes mellitus.
It's a huge topic.
It is. And this isn't just a basic overview of, blood sugar control. This deep dive is our mission to give you a thorough, modern understanding of diabetes.
Right, from the microscopic mechanics of the beta cell.
All the way up to the revolutionary drug classes and technologies that are completely reshaping chronic care today. We're taking a complex stack of sources and boiling it down to the essential, fascinating takeaways.
It's an urgent mission, really. When we talk about diabetes mellitus, we are discussing a clinical syndrome, and it's defined by sustained hyperglycemia.
High blood sugar.
Exactly. And the term mellitus is actually derived from the Latin word for sweet.
Which is a historic nod to the sugar that would be present in the urine.
Precisely. A very old diagnostic sign.
And the scale of this sweet burden is just hard to overstate. It's not a niche problem, it's a global giant.
It truly is. Our sources confirm that globally, 463 million people had diabetes back in 2019.
463 million.
Yeah. That's a staggering 9.3% of the world's adult population. And, the projections are not encouraging. We anticipate that figure will soar to 700 million by 2045.
Wow. A public health crisis of that magnitude must carry an equally massive financial cost.
It does. The economic impact is colossal and, frankly, difficult to grasp fully. In 2017, the estimated global healthcare expenditure attributed to diabetes was at least $727 billion US.
727 billion.
Billion, yes. And to put that in context, that single disease accounted for 10% of total global healthcare spending.
One in every $10.
On one condition. And when you look at where the prevalence lies, it's mostly type 2 diabetes, or T2D. That accounts for roughly 90% of cases.
Okay, so the vast majority.
The vast majority. Type 1 diabetes, T1D, makes up most of the remainder. And if you look at developed nations like the U.S., over 20% of adults aged 65 and older are living with type 2 diabetes.
So it's heavily weighted toward aging, more insulin-resistant populations?
Exactly.
Those numbers really frame why this conversation is so essential. But regardless of whether we're talking about type 1 or type 2, the clinical outcome always comes down to a failure of insulin.
Exactly. All forms of diabetes, even the very rare ones, ultimately result from an issue with insulin. Specifically, it's either an absolute or a relative deficiency.
Let's unpack that distinction because it's really the core difference between type 1 and type 2.
Yeah.
So when we talk about T1D, we are talking about an absolute deficiency.
Precisely. In type 1 diabetes, the body's immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas.
So the insulin factory is destroyed.
It's gone. There is little to no endogenous insulin being made, which is why we call it an absolute deficiency.
And T2D is fundamentally different. It's a relative deficiency.
That's right. T2D is characterized, at least initially, by elevated circulating insulin concentrations because the body is trying desperately to compensate. The problem is that the peripheral tissues, muscle, fat, the liver, they're highly resistant to insulin signals.
So the body has plenty of insulin, it's just not working properly.
It has a lot of insulin, but it requires much, much more than normal to achieve the same effect. It's a relative deficiency, typically linked to obesity. And eventually, the beta cells simply exhaust themselves trying to keep up with that impossible demand.
To understand the failure, we have to appreciate the machinery. So let's start on the factory floor, the beta cell. It seems incredible that such a vital process happens at a place that's so tiny.
It is genuinely remarkable. Insulin is synthesized in the beta cells, which are the dominant cell type, about 70% within these structures called the islets of Langerhans.
Okay.
We have roughly 1 million of these islets scattered throughout the pancreas. Their total mass is less than a single gram, yet they are metabolic powerhouses.
Less than a gram.
And to ensure they can communicate quickly with the body, they receive a disproportionate amount of blood, 10 to 15% of the total pancreatic blood flow.
So they're incredibly well supplied.
Very.
And the production process itself is fascinating. Insulin isn't just secreted on its own, it's manufactured alongside a silent partner, so to speak.
Correct. Insulin starts out as proinsulin. This prohormone is then cleaved or split into the active insulin molecule, which is made of the A and B chains, and a fragment called C-peptide.
C-peptide.
And the crucial point for clinicians and researchers is that insulin and C-peptide are produced in equimolar amounts.
Meaning 1 for 1.
Exactly. So if you can measure the C-peptide, you know exactly how much endogenous insulin the patient's body is still making, even if they are injecting synthetic insulin from an external source.
So C-peptide is like the exhaust pipe of the insulin factory, a perfect, traceable byproduct. Now let's get into the moment-to-moment control. How does the beta cell sense, with such incredible precision, the exact concentration of glucose in the bloodstream?
Well, it uses a very specialized molecular sensor. First, glucose enters the beta cell through these transporters, GLUT1 or GLUT2.
Okay, so it gets through the door.
It's inside. And the moment it's inside, an enzyme called glucokinase, or GK, converts that glucose into glucose 6-phosphate, and that starts the whole energy-generating process.
And why is glucokinase the star of the show here? What makes it so important?
Because it is the crucial physiological sensor. The rate at which glucokinase works is directly proportional to the amount of glucose outside the cell.
So it's a speedometer.
It's the perfect analogy. If glucose is high, GK works fast. If glucose is low, GK works slowly. It is essentially the speedometer that determines the pace of the entire insulin production and release cascade.
Okay, so the sensor, the speedometer, reads glucose is high. What happens next electrically?
The metabolism of all that glucose generates ATP, adenosine triphosphate. The rise in ATP concentration then signals a critical gate to close. This is the ATP-sensitive potassium channel, or KATP channel.
Right, the KATP channel.
And this channel is a complex structure made up of KIR6.2 and SUR1 subunits. But the key is, when this channel closes, potassium can no longer leave the cell, and that causes the cell membrane to depolarize.
So the cell goes from chemically sensing glucose to generating an electrical charge.
Right.
That charge must then open the final gate.
Precisely. The depolarization triggers the opening of voltage-sensitive calcium channels, allowing calcium, CO2 plus MANT to just flood into the cell.
Okay.
And this massive influx of intracellular calcium is the final signal that causes the insulin's secretory vesicles. These are the ready-to-go packages of insulin to fuse with the cell membrane, and that leads to rapid secretion. It's a remarkably elegant, coupled system.
And that release isn't just a continuous flow, it's a calculated biphasic response. Tell us about the two phases of insulin release.
Right, so when you eat a meal, the beta cell responds with two distinct phases. First, there's a very rapid first phase. This is the immediate release of preformed insulin that was already synthesized and stored.
The emergency stash.
It's the emergency stash, exactly. And it's all done within about 15 minutes.
So the body is clearing that immediate glucose spike from the meal.
Right. And following that, there's a more gradual, sustained second phase, which can last for 2 or 3 hours. And this phase involves the beta cells actively synthesizing new insulin to maintain control while all those nutrients are still being absorbed.
And the context for this is vital, which brings us to something called the incretin effect.
Yes.
This is one of the most important concepts for understanding modern drug therapy, but it started out as just a clinical curiosity, didn't it?
It did, yeah. The observation was really simple. If you ingested glucose orally, you release significantly more insulin than if you administered the exact same amount of glucose intravenously.
Even if the blood sugar curves were identical.
Even if they were identical, the gut was clearly involved in some way.
So the gut was acting as a brilliant pre-warning system, telling the pancreas to prepare for impact.
That's the incretin effect. It's mediated by these hormones, GLP-1 and GIP. GLP-1 comes from L cells in the lower gut, and GIP comes from K cells in the upper gut. They get released when nutrients hit the small intestine, and they massively amplify the insulin response.
But, and here's the crucial aha moment for type 2 diabetes.
This is it. This natural amplifying effect is significantly diminished in people with type 2 diabetes. And that realization, that simple fact, opened up a completely new therapeutic avenue.
So insulin is the anabolic commander, telling the body to store fuel.
Right.
But what prevents us from plummeting into a dangerous low-state hypoglycemia between our meals?
That is the counter-regulatory function, and it's led by glucagon. Glucagon is produced by the alpha cells in the islet, right next to the beta cells.
And it does the exact opposite of insulin.
The exact opposite. It primarily targets the liver to stimulate glycogenolysis. That's breaking down stored glycogen and hepatic glucose production. This ensures a steady glucose supply and is absolutely critical for preventing crashes.
And just to summarize insulin's ultimate mission.
Insulin is anabolic. It promotes the storage of fuel. So building glycogen stores in the liver and muscle, promoting triglyceride synthesis in adipose tissue. And in terms of lowering glucose, its key action is mobilizing these things called GLUT4 transporters.
Okay, what do they do?
They're protein shuttles, and they move from the interior of muscle and fat cells up to the cell membrane. They act like open doors that allow glucose to be sucked rapidly out of the bloodstream and into the cells.
And when insulin is absent or low, the body switches from that storage mode to a kind of crisis mode, which involves fat breakdown and ketone production.
Precisely. Low insulin is a signal for the body to mobilize stored energy, so it permits lipolysis, the breakdown of fat-releasing free fatty acids, or FFAs, and glycerol.
Right.
In the liver, the partial oxidation of these FFAs provides the energy needed for making new glucose, and it also produces ketones, acetoacetate, beta-hydroxybutyrate, and acetone.
Which the brain can use as fuel.
It's an alternative fuel for the brain, a survival mechanism. But when that production is unrestrained, like in absolute insulin deficiency, it very quickly becomes toxic.
Now we shift from that beautiful physiology to the rigorous science of diagnosis.
Yeah.
And the diagnostic cutoffs, they aren't arbitrary. They are based on a very specific clinical risk.
Absolutely. The established diagnostic thresholds are fundamentally based on identifying the glucose level above which there's a statistically appreciable risk of developing the microvascular complication of diabetic retinopathy.
Damage to the small vessels in the back of the eye.
Exactly.
So what are the specific thresholds we use in the clinical setting?
Diabetes is confirmed if a patient presents with a random plasma glucose concentration of 11.1 millimole or more, or a fasting plasma glucose of 7.0 millimole or more,
Okay.
or, and this is the most common modern measure, an HbA1c result of 48 millimole or higher.
And there's a key rule for asymptomatic patients.
Yes. For any patient who is asymptomatic, meaning they don't have those classic symptoms like thirst or frequent urination, it is mandatory to have 2 diagnostic tests to confirm the diagnosis.
And a critical side note, finger prick tests shouldn't be used for diagnosis.
Absolutely not. Capillary blood glucose should never be used to make the final diagnosis due to accuracy issues. We need venous plasma measurements from a proper lab.
Let's linger on HbA1c, glycated hemoglobin, because it gives us a timeline, not just a snapshot. What exactly is the top window it's looking at?
So HbA1c reflects the average blood glucose over the lifespan of the erythrocyte, the red blood cell, which is about 120 days.
3 to 4 months.
Roughly. Glucose slowly and non-enzymatically attaches to the hemoglobin protein inside that red blood cell. And once it's attached, it stays there. So it provides this integrated long-term picture.
But it's weighted more towards the recent past, right?
It is, yes. While it covers 3 to 4 months, it is most sensitive to changes in glycemic control that occurred in the 30 days immediately preceding the measurement.
And going back to that retinopathy risk, you mentioned the thresholds are set based on a danger zone.
Yes. If you map the incidence of retinopathy against glucose levels, you see a clear pattern. While some mild risk starts around 4 millimole, the major inflection point, where the risk of developing that microvascular damage dramatically accelerates, occurs when glucose consistently exceeds 8 millimole.
So that scientifically justifies why our diagnostic and treatment targets are set where they are.
Exactly. We are trying to keep the patient below that critical risk threshold.
Now, as useful as HbA1c is, it is not foolproof. Clinicians have to be aware of situations where that average measurement can be misleading.
Yes, absolutely.
So tell us about the key pitfalls that can lead to an erroneous HbA1c reading.
The key is anything that alters the red blood cell lifespan. If the lifespan is shortened for some reason, the HbA1c reading will be artificially low.
Okay, what kind of conditions do that?
Things like sickle cell disease, thalassemia, chronic blood loss, a recent blood transfusion, or even pregnancy.
And conversely, if the red cell lifespan is prolonged, the reading will be artificially high.
Exactly. This happens in deficiencies of vitamin B12 or folate, which slow down red cell turnover or after a splenectomy. We have to treat the patient, not just the number, and recognize these common hematological caveats.
And what about that intermediate zone, the definition of pre-diabetes? Does that mean they are just a little bit diabetic?
Well, prediabetes is classified as either impaired fasting glucose, IFG, or impaired glucose tolerance, IGT. They aren't currently considered to have microvascular disease risk.
But they do face other risks.
They face 2 key risks. First, progression to overt diabetes. About 5 to 10% of these individuals will progress each year. And second, and this is often overlooked, they have an increased risk of macrovascular disease, heart attacks, and strokes, especially those classified with IGT.
When a patient is already using insulin, we need a way to track the output of their own beta cells. And this is where that C-peptide testing, our exhaust pipe marker, becomes clinically essential.
Precisely. Since synthetic insulin does not contain C-peptide levels reliably mark the remaining endogenous insulin secretion. Very low levels, typically less than 200 pmols, are highly suggestive of severe deficiency, which is characteristic of type 1 diabetes.
And on the flip side,
Conversely, elevated levels, say over 900 pmol, suggest type 2 diabetes or severe insulin resistance, where the body is overproducing insulin, but it's just not effective.
and there's an essential catch to getting a clean C-peptide result, isn't there?
Yes, this is critical. You must ensure the patient's blood glucose is simultaneously above 4.0 millimanol. If the patient is hypoglycemic, the body naturally suppresses insulin secretion, which would artificially give you a low C-peptide result and could lead to a misdiagnosis.
And finally, for a definitive type 1 diagnosis, we need to see the fingerprints of the autoimmune attack, the islet autoantibodies.
These are essential for confirmation, as they show the immune system is actively targeting the beta cells. We look for three main types: anti-GAD, anti-IA2, and anti-ZNT8.
And the number of antibodies matters.
It matters a lot for prognosis. The risk of developing overt T1D increases dramatically with the number of antibodies present. If a patient tests positive for 3 of these autoantibodies, their risk of developing type 1 diabetes is a substantial 70%.
This brings us to the revolution in daily monitoring. Continuous glucose monitoring, or CGM. This technology has really changed management, moving us beyond painful finger pricks. How does this system function, and why is there that slight delay in its readings?
So CGM uses a tiny sensor, often placed on the arm or abdomen, to measure glucose in the interstitial fluid, that's the fluid between the cells, rather than directly in the blood.
Okay.
It provides continuous data, a current reading, trend arrows showing the velocity and direction of glucose change, and these comprehensive daily profiles compiled into an ambulatory glucose profile, or AGP.
And the lag.
The reason for the delay is physiological. It just takes time for glucose concentrations to equilibrate between the blood and that interstitial fluid. This results in a 10 to 15-minute lag when blood glucose is changing rapidly, like during intense exercise or right after a mealtime bolus.
That lag is a critical piece of safety information, but the overall utility and accuracy must be impressive to justify its adoption.
They are. Accuracy is quantified by the MARD, the mean absolute relative difference, which for newer devices is now typically reported as less than 11%.
And the real utility is in the data.
It's all in the data. CGM allows clinicians and patients to visualize patterns that intermittent testing misses entirely. Things like nocturnal hypoglycemia or severe post-meal spikes that resolve really quickly. The integration of trend arrows and alarms for impending highs or lows empowers proactive rather than reactive management.
What's the difference between the two main types of CGM a patient might encounter?
We distinguish between a TGM, which is intermittently scanned, and RT-CGM, which is real-time. The SCGM, or flash devices, require the patient to actively scan the sensor to get a reading. And crucially, if the patient doesn't scan for 8 hours, the data stored in the sensor's memory is lost.
So you can lose information.
You can. Whereas RT-CGM devices continuously transmit data to a receiver or a smartphone in real time and provide automatic alarms without needing an active scan. Both are now the standard of care, but RT-CGM is definitely superior for patients who are highly prone to, say, nocturnal hypoglycemia.
Moving to the physical assessment. Given that diabetes is a systemic disease that affects every organ, a routine checkup could feel overwhelming. But our sources highlight a very focused, practical approach in clinical practice. What is the essential learner's shortcut for routine screening?
In routine clinical practice, the focus is entirely on complication screening. The 4 crucial routine checks that should happen at almost every visit are blood pressure measurement, a meticulous foot examination, checking both circulation and sensation, inspection of insulin injection sites to identify lipohypertrophy.
Those are the lumps of fat that can impede absorption.
Exactly. And finally, confirming that the patient is up to date with their retinal screening.
Let's pull back and look at some of the non-routine signs, physical clues that might confirm a diagnosis or signal severe insulin resistance, starting with the skin.
Cutaneous markers can be very revealing. The most common is probably acanthosis nigricans.
Okay, what does that look like?
It's a velvety, dark pigmentation that you typically see in the axillae, the neck folds, and the groins.
Right.
It's a very powerful marker that is strongly associated with severe insulin resistance, often seen in T2D.
And there's another more specialized rash.
Yes, necrobiosis lipoidica diabeticorum. It's less common, appears mainly over the shins, and is characterized by a shiny, scarred central yellow area that's surrounded by a red active margin.
And what might a clinician spot just by observing the head and eyes?
Well, observing the face might reveal xanthelasma, which are benign lipid deposits clustered around the eyelids, and they signal an underlying dyslipidemia that's associated with metabolic syndrome. We also look for more acute signs, like cranial nerve palsies that cause eye drooping, or ptosis, or that deep sighing Kussmaul's breathing, which is the body attempting to blow off the carbon dioxide caused by metabolic acidosis in DKA.
The musculoskeletal associations are often surprising. The hands, for instance, can tell a story of long-term hyperglycemia.
They absolutely can. Diabetes often causes musculoskeletal complications because that long-term high glucose leads to the glycation of collagen, making tissues less elastic.
And this leads to stiffness.
Exactly. It leads to limited joint mobility or chiroarthropathy, causing painless stiffness, particularly in the hand joints. This is famously demonstrated by the prayer sign.
The prayer sign.
Yes, it's the inability to fully flatten the hands together, palms touching, due to stiffness in the MCP or IP joints of at least one finger on both hands.
That prayer sign is a very memorable visual cue.
It is. And other common associations include Dupuytren's contracture, carpal tunnel syndrome, and trigger finger. All of these are significantly more prevalent in people with diabetes.
Finally, the critical foot exam. We really need to spend time here because failure to detect issues leads directly to ulceration and ultimately amputation. How should a clinician approach this systematically?
The foot exam is structured to detect the two primary risks, neuropathy and peripheral vascular disease. First is inspection. We look for any break in the skin, like ulcers, signs of infection, or discoloration. A dusky, bluish color signals critical ischemia.
Okay.
We check for callus, which is often a precursor to ulceration, and for deformities like clawing of the toes or loss of the plantar arch, which are telltale signs of neuropathy.
And if the foot is severely deformed and swollen?
Or if the skin temperature is noticeably raised, we must consider Charcot neuroarthropathy, which is a destructive joint disease.
And then you move on to assessing circulation and sensation.
For circulation, we check the dorsalis pedis and posterior tibial pulses annually. If both pulses are absent, the patient is immediately classified as having a moderate risk of ulceration, even if their sensation is perfectly normal.
And for sensation, we move from just gross testing to a very specific prognostic tool.
The standard for sensory testing is the 10-gram monofilament. This is a specialized nylon thread that's applied gently until it just bends, guaranteeing a consistent, low-level pressure.
And you test it at specific sites.
At 5 specific sites on the toes and metatarsals. And if sensation is absent in even one of those 5 places, the patient's risk of developing a foot ulcer increases dramatically by 5 to 10-fold. This simple tool provides immense prognostic value and dictates the urgency of referral to a podiatrist.
We've diagnosed it, we've screened for complications, now we must understand the cause. Let's return to type 1 diabetes and the detective story of that immune attack.
So T1D pathogenesis is a result of a T-cell-mediated destruction of the beta cells. We call it insulitis, and it's driven by a combination of genetics and environment.
And the T cells are the final executioners.
They are the ultimate effectors, yes. But the presence of autoantibodies, like anti-GAD, signals the initiation of this process, often many months or even years before the patient experiences any symptoms. It's a very slow-burn destruction.
What are the primary genetic suspects that make someone susceptible?
There is a strong polygenic influence. The concordance rate in monozygotic or identical twins is 30 to 50%.
So, strong but not purely genetic.
Exactly. It shows a strong but not singular genetic component. The most dominant genetic link involves the HLA region on chromosome 6. Specifically, the HLA haplotypes DR3 and DR4 are strongly associated with risk, particularly in populations of European descent.
And the environmental trigger remains the great unknown. What are the current leading theories for what flips that autoimmune switch?
We have several categories of suspects. Firstly, viruses, notably enteroviruses like Coxsackie B4, mumps, and rubella, which may induce inflammation or mimic beta cell antigens. Secondly, certain toxins or early dietary exposures like dietary nitrosamines or bovine serum albumin in cow's milk, where antibodies raised against it might cross-react with islet proteins.
And then there's the hygiene hypothesis.
Right. That suggests that reduced exposure to microbes in early life alters immune development. And finally, low levels of vitamin D are consistently implicated given the higher incidence of T1D we see in northern latitudes.
When T1D is clinically diagnosed, the patient has usually lost the vast majority of their beta cell mass. But then comes that temporary reprieve you mentioned earlier, the honeymoon period.
It is a fascinating phenomenon. After insulin therapy is initiated, the body's metabolic environment improves drastically. The reversal of severe hyperglycemia, or what we call glucotoxicity, allows the small remaining fraction of beta cells to recover function temporarily.
And so their insulin needs plummet.
They experience a dramatic reduction in their need for exogenous insulin.
Does preserving even that minimal function matter in the long run?
It matters immensely. Studies show that persistent endogenous insulin secretion, which we track with detectable C-peptide, is strongly associated with better outcomes.
Like what?
Reduced glucose variability, lower HbA1c overall, a significantly lower risk of hypoglycemia, and fewer microvascular complications decades later. This is why so much research into T1D focuses on preserving those last functional beta cells.
Shifting to type 2 diabetes, this is defined by that dual defect: insulin resistance and then subsequent beta cell dysfunction. How extensive is that beta cell failure by the time of diagnosis?
It's significant. It's estimated that roughly 50% of functional beta cell mass is already lost by the time T2D is clinically diagnosed. The system has been struggling for years before that point.
And the natural history shows how these two defects interact over time.
We can visualize it. Initially, as insulin resistance increases due to weight gain and lifestyle factors, the beta cells heroically compensate by massively increasing their insulin output, and that keeps blood glucose normal.
But they can't keep it up forever.
The demand is just too high. The beta cells begin to fail, often due to a combination of glucotoxicity, lipotoxicity, and amyloid deposition. And once they fail, that compensatory insulin output drops, and plasma glucose begins its uncontrolled rise, leading to overt diabetes.
What drives the genetic component of T2D? It's much more complex than T1D.
Unlike T1D, T2D is profoundly polygenic, with over 400 different gene variants identified. And interestingly, most of these variants relate to subtle defects in beta cell function rather than the resistance pathways.
And is there one that stands out?
The variant with the single largest impact in the general population is in the gene TCF7L2. 10% of the population carry 2 copies of this risk allele, which nearly doubles their lifetime risk of developing type 2 diabetes.
And what are the physical drivers of that initial defect? Insulin resistance.
Well, the primary physiological driver is central obesity. Specifically, the accumulation of visceral adipose tissue. That's the fat around the organs.
And that fat is metabolically active.
It's highly active. It releases free fatty acids and these inflammatory hormones called adipokines. These substances circulate and inhibit glucose use in muscle cells and reduce the liver's sensitivity to insulin. We also see higher prevalence in specific ethnicities, South Asians, Hispanic, and Black populations, and of course, lacks physical activity.
And these factors are the hallmarks of what we call the metabolic syndrome.
Yes. The syndrome is defined by a cluster of features all associated with insulin resistance. Hypertension, a specific form of dyslipidemia, high triglycerides, low HDL, and non-alcoholic fatty liver disease. This entire cluster dramatically increases both cardiovascular and overall mortality risk.
Now let's talk about the remarkable single-gene forms of diabetes, the monogenic types, which, though rare, offer these amazing clinical opportunities.
Monogenic diabetes, predominantly maturity-onset diabetes of the young, or MODY, accounts for about 4% of diabetes diagnoses in people under the age of 30. The key diagnostic feature is its dominant inheritance pattern, often affecting 3 or more generations.
Give us the highlights of the different MODY subtypes, particularly how their treatments can diverge so wildly.
They are drastically different. GCK MODY is caused by a mutation in glucokinase, the sensor we talked about. These patients essentially have a high but stable glucose set point.
So they just run a bit high.
They do. They typically have high fasting glucose, but a relatively normal HbA1c, and they rarely require treatment or develop complications. They're usually best left alone.
And contrast that with HNF1 alpha MODY.
Yes, contrast that with HNF1 alpha and HNF4 alpha MODY. These involve defects in transcription factors, and these patients are extremely sensitive to sulfonylurea drugs.
So a genetic diagnosis here is life-transforming.
Absolutely. Patients who may have been misdiagnosed with T1D and treated with insulin for years can often stop insulin completely and switch to simple, inexpensive oral sulfonylureas.
And the final subtype is HNF1 beta MODY.
That mutation is known for its multi-system involvement. It causes progressive diabetes and is also associated with extrapancreatic features like renal cysts and malformation of the genital tract, because that transcription factor is vital for the development of those organs too.
But the most stunning intervention might be found in neonatal diabetes diagnosed within the first 6 months of life.
This is a perfect example of personalized medicine. Approximately two-thirds of permanent neonatal diabetes cases are caused by an activating mutation in the KATP channel subunits, that very gate we discussed earlier.
So, because sulfonylurias directly target and close that channel.
Genetic testing leads to a life-changing switch. Over 90% of these infants and children can be safely and effectively switched from chronic insulin injections to oral sulfonylurea treatment.
And it has benefits beyond blood sugar.
It does. It often also improves or prevents associated neurological problems like epilepsy because those same KATP channels are found in the brain.
The acute complications of diabetes are metabolic catastrophes. They're life-threatening and require immediate, very distinct management protocols based entirely on whether the patient has an absolute or relative insulin deficiency.
That's right.
Let's start with diabetic ketoacidosis, or DKA, the complication of absolute insulin deficiency. What is the fundamental defining biochemical triad?
DKA is defined by the triad of hyperglycemia, so a blood glucose over 11.1 millimole, hyperketonemia with blood ketones of 3.0 millimole or higher, and metabolic acidosis with the venous pH less than 7.3. All three must be present.
How does the total lack of insulin so quickly unravel the entire metabolic state?
Without insulin, counterregulatory stress hormones just run rampant. This leads to unrestrained lipolysis, flooding the liver with FFAs, and driving massive, uncontrolled ketogenesis.
And at the same time, the high sugar is causing dehydration.
A profound osmotic diuresis. The patient urinates excessively to try and clear the glucose, leading to severe dehydration. The average water loss is around 100 milliliter per kilogram of body weight. And the accumulation of all these acidic ketones causes the pH to drop dramatically.
What are the key clinical signs a medical team would see upon presentation?
Patients often look very ill. They exhibit symptoms of severe dehydration, hypotension, and often present with nausea, vomiting, and severe abdominal pain, which can sometimes mimic surgical emergencies.
And the breathing.
You might observe Kussmaul's breathing, which is that deep, labored breathing. The patient is trying to compensate for the acidosis by blowing off CO2, and they may have the characteristic sweet smell of acetone on their breath.
DKA management is a fast, aggressive protocol. Can you detail the three critical pillars of initial treatment?
DKA is a true medical emergency. First, intravenous fluids. We have to rapidly correct the circulatory and extracellular fluid deficit, typically starting with 0.9% saline, often administering 1 liter over the first 60 minutes.
Okay, fluids first.
Then second, intravenous insulin. We start a fixed-rate insulin infusion, or FRII, for example, at 0.1 units per kilogram per hour. And that insulin infusion is continued until the DKA is resolved.
And third is potassium.
Potassium replacement. While patients are usually hyperkalemic initially, their total body potassium is very depleted. We start replacement only if their serum potassium is in a safe range and they're passing urine.
And you add glucose later.
We start a glucose infusion once the blood glucose drops below 14 millimole because that allows us to continue the insulin infusion needed to clear the remaining ketones without causing hypoglycemia.
We often hear DKA is linked to T1D, but it does occur in a small subset of T2D patients.
That's right. 10 to 15% of DKA cases occur in type 2 patients. It's often called ketosis-prone diabetes or Flatbush syndrome. They present with DKA, requiring initial insulin, but because their beta cells can recover function once the toxic glucose environment is cleared, they often successfully transition back to oral medications within 3 months.
Now let's contrast DKA with the hyperglycaemic hyperosmolar state, or HHS. This is a much slower process, typically seen in older, frailer patients.
HHS is characterized by profoundly severe hyperglycemia, often over 30 millimole, and severe hyperosmolality, generally over 320 mosmolk. But crucially, the main difference from DKA is the minimal ketonemia and minimal acidosis.
So how can the insulin deficiency be strong enough to cause a sugar reading of 30, but still weak enough to suppress ketone production?
It's because this condition develops over days to weeks. The relative insulin levels, while they're far too low to move glucose out of the blood, are still just high enough to inhibit lipolysis in the fat cells.
So no fat breakdown, no ketones.
Exactly. Ketogenesis is suppressed. But this extended development time leads to absolutely staggering fluid loss, up to 10 or even 22 liters in a heavy individual, and causes severe neurological symptoms because of the extreme osmolality.
Given the frailty of these patients and the massive dehydration, the management must be more nuanced than the rapid fluid replacement used in DKA.
Mortality is much higher in HHS, up to 20%. So management requires a slow, extremely cautious approach. The priority is fluid replacement using 0.9% saline alone. We aim for a slow, steady decrease in osmolality, targeting only 3 to 8 mosmol per kilogram per hour.
And insulin comes much later.
We typically introduce insulin only after fluid replacement is well underway and the blood glucose fall has plateaued. This slow and cautious approach is absolutely essential to prevent rapid fluid shifts that could lead to cerebral edema and death in that severely dehydrated brain.
The ultimate goal of all this knowledge is effective management. Let's start with targets, which have to be personalized and based on clinical evidence.
Therapeutic targets must be individualized. The standard HbA1c goal is 53 milliorimol, or 7%, for both T1D and T2D.
But it's not one size fits all.
Not at all. For younger, low-risk patients who can achieve it safely, a stricter target of 48 millimol is often sought. Conversely, for older, frail patients or those with significant comorbidities or high hypoglycemia risk, a higher, more forgiving target of 58 millimol is accepted. We prioritize safety over absolute glycemic perfection.
And these targets are built on the back of landmark clinical trials. Tell us about the profound concept of metabolic memory that was established by these studies.
The two foundational trials are DCCT in type 1 and UKPDS in type 2. DCCT showed that intensive glucose control reduced microvascular risk by 60%. But critically, the long-term follow-up showed that those benefits persisted for decades, even if glucose control worsened later.
That's metabolic memory.
That's it. Early, aggressive control sets a destiny for your blood vessels that lasts a lifetime. UKPDS similarly showed that intensive control in T2D reduced microvascular risk and uniquely showed that metformin treatment in overweight participants specifically reduced diabetes-related death.
And thanks to CGM, we now have a metric that gives us richer, moment-to-moment insight than a single HbA1c ever could. Time in range, or TIR.
TIR is the modern gold standard. It shifts the focus from an average number to the quality of day-to-day control. International consensus defines in range as spending time between 3.9 and 10 millimol.
Yeah, and what's the goal?
The optimal goal for most people is achieving 70% or more of their time within that therapeutic window. And it's worth noting that pregnancy requires even stricter, narrower targets.
Let's discuss the foundational role of education and lifestyle modification, starting with type 1 diabetes.
For T1D, mandatory structured education programs like DAFNE in the UK are absolutely essential. The core skill they teach is carbohydrate counting.
A constant calculation.
It is.
Yeah.
The patient calculates their mealtime insulin dose based on 3 factors. First, the carbohydrate content of the meal, using their specific insulin to carb ratio. Second, their current blood glucose level, using a personal insulin sensitivity factor. And third, adjustments for variables like planned exercise or alcohol. It's highly demanding.
And for type 2 diabetes, the lifestyle goal is often more aggressive, even aiming for remission.
Exactly. While dietary approaches vary, often focusing on Mediterranean principles and minimizing processed foods, the critical takeaway is the power of weight loss. Substantial, sustained weight loss, specifically around 15 kilograms or 15% of initial body weight, has been proven in clinical trials to induce remission in a significant percentage of people with type 2.
Often allowing them to stop their medication.
For a time, yes.
Moving to crucial safety and legal requirements, particularly concerning driving while on insulin. This is a significant concern due to the risk of hypoglycemia.
It is paramount. In the UK, for example, insulin users must notify the DVLA. And specific rules are in place. The blood glucose must be at least 5.0 millimol out before starting a journey.
Okay.
They have to check their blood glucose every 2 hours during long journeys. And if hypoglycemia occurs, the driver has to consume fast-acting carbohydrate and then wait a mandatory 45 minutes after correction before driving again.
By the way,
because of documented delayed recovery of cognitive function, your brain just isn't fully back online, even if your sugar level is. CGM technology has been approved for monitoring while driving, which adds a great layer of safety.
what about religious requirements, like fasting during Ramadan? This requires highly specialized counseling.
Patients with diabetes intending to fast should schedule a specialist review 6 to 12 weeks prior to Ramadan. Counseling covers fluid intake, meal timing, and treatment adjustment. A key educational point is that glucose monitoring does not invalidate the fast.
And some medications are safer than others.
Absolutely. When adjusting medications, the safest agents are those that do not cause hypoglycemia, like DPP-4 inhibitors or GLP-1 receptor agonists.
Now, the revolution in type 2 pharmacology. The last decade has introduced drug classes that dramatically change the outcome for high-risk patients, moving far beyond just sugar control.
We start with metformin, which is a big one-eyed, and it remains the first-line therapy. It's cost-effective and proven. Its complex mechanism involves inhibiting mitochondrial respiration and activating AMPK.
And it has a great safety profile.
It causes modest weight loss, is weight neutral regarding hypoglycemia risk, and carries that critical UKPDS legacy benefit of reducing myocardial infarction risk in overweight patients. Its main limitation is that the dosage must be reduced based on the patient's kidney function, their eGFR.
Next, the injectables that mimic the body's own signals, GLP-1 receptor agonists.
GLP-1 RAs mimic the action of that diminished incretin hormone GLP-1. They are glucose-dependent insulin secretagogues, meaning they only stimulate insulin when glucose is high, which minimizes hypoglycemia risk.
But their major benefits are extraglycemic.
They delay gastric emptying and act centrally on appetite centers in the brain, leading to significant sustained weight loss, typically 3 to 5 kilograms. But most importantly, they provide powerful cardiovascular protection, reducing the risk of heart attacks, stroke, and cardiovascular death in outcome trials.
The main side effect is nausea.
Initially, yes. Mostly gastrointestinal side effects that tend to settle.
And the second game changer, the SGLT2 inhibitors, or flozines, which act entirely on the kidney.
These drugs exploit renal physiology. They block the sodium glucose cotransporter 2, or SGLT2, in the proximal tubule of the kidney. This prevents the reabsorption of about 25% of the glucose filtered by the kidney.
So you just pee out the sugar.
You pee out the sugar.
Yeah.
This causes glycosuria, which promotes weight loss and natriuresis sodium loss, leading to a reduction in blood pressure.
And their protective benefits are astounding, particularly for the heart and kidneys.
They are arguably the biggest pharmacological breakthrough of the last decade. SGLT2 inhibitors offer robust cardiovascular protection, particularly reducing the risk of hospitalization for heart failure, even in non-diabetic patients.
Come for the kidney.
They also provide proven renal protection, significantly slowing the progression of kidney disease and reducing the need for dialysis. They achieve this, in part, by decreasing pressure inside the glomerulus.
What are the key adverse effects clinicians and patients need to watch for with SGLT2 inhibitors?
Well, because of the glucose in the urine, genital fungal infections are relatively common, affecting 5 to 10% of users. More seriously, there's a rare but critical risk of euglycemic DKA.
So DKA with normal blood sugar.
DKA occurring despite the patient having normal or near normal blood glucose because the drug is causing all that glucose loss. Because this is so counterintuitive and dangerous, patients must be educated to stop the drug during any acute illness, surgery, or prolonged fasting.
And we should briefly cover the other agents.
Sure. DPP-4 inhibitors, or gliptins, prevent the breakdown of GLP-1. They are well tolerated, weight and cardiovascular neutral, and have a low hypoglycemia risk. Sulfonylureas are older, effective agents that directly force the KATP channel closed, but they carry a significant risk of hypoglycemia and weight gain. And TZDs, or glitazones, increase peripheral insulin sensitivity but carry risks of fluid retention, exacerbating heart failure, and bone fracture.
Finally, the evolution of insulin delivery itself. Analog insulins were a major step forward from the traditional human insulins.
Analog development involves small engineered changes to the amino acid sequence to optimize the time-action profile. Rapid-acting analogs like Lispro and Aspart are designed to prevent the formation of large insulin hexamers, so they dissociate quickly and achieve a rapid onset of action.
And long-acting analogs do the opposite.
They are engineered to prolong duration. Glargine achieves this by being less soluble at physiological pH, causing it to precipitate and dissolve slowly. Degludec uses long fatty acid chains to form these multihexamers that slowly break down over more than 40 hours.
And for type 1 management, this technology combines into the ultimate system, the continuous subcutaneous insulin infusion pump, or CSII.
CSII devices deliver continuous basal insulin and allow the patient to deliver precise boluses on demand. But when these pumps are paired with real-time CGM systems, they become sensor-augmented systems.
And this integration is transforming care.
It is. These sophisticated systems can use predictive algorithms to interrupt insulin delivery when they anticipate hypoglycemia, often virtually abolishing the risk of severe, particularly nocturnal, hypoglycemia.
This deep dive has covered an immense amount of ground. From the elegance of glucokinase acting as a glucose sensor and the life-transforming potential of genetic diagnoses and MODY, all the way to the clinical urgency of DKA management.
It's a huge field.
It is. And we've established that managing diabetes is complex, it's individualized, and it's incredibly demanding for the patient who is constantly balancing carb counting, injection timing, and complication risk.
And we've seen how the pharmaceutical landscape has shifted away from solely focusing on blood sugar control. The realization that certain drugs offer protection for the heart and kidney is a profound change in strategy.
So as we leave you today, let's wrap up with that provocative thought for you to consider. Given the compelling independent data showing that SGLT2 inhibitors and GLP-1 receptor agonists provide robust cardiovascular and renal protection benefits that occur before and often independent of the glucose-lowering effect, how might future international guidelines evolve?
It's the big question.
Will we see these drugs prioritized as first-line therapy, even for patients whose HbA1c is only mildly elevated, shifting the focus from treating high sugar to preventing catastrophic outcomes like heart failure and kidney failure? That prioritization of prevention over glycemic metrics is really the defining scientific debate of the next decade of diabetes care.